Hello and welcome everybody to the Davis Finney Foundation Live Well Today webinar series. I'm really glad that you're here. My name is Melanie Dizon. I'm the Director of Education and Content at the Davis Finney Foundation, and I'm excited to be here today with Dr. Salima Brillman to talk about nOH and Parkinson's. Thank you so much for being here today, Dr. Brillman.
My pleasure. Thank you so much for having me. I appreciate it.
Great. So let's get to it. Dr. Brillman, first, can you just tell everyone watching who you are, what you do, and how you got interested in this work, and in particular, nOH and some of the non-motor symptoms of Parkinson's?
Sure. So I'm Salima Brillman. I am a movement disorder neurologist in Palo Alto, California. I finished my fellowship in 2006, and I was telling Mel how happy I am to be invited to do this particular talk. I have really a passion for nOH, and I think it's not very well recognized. It's definitely undertreated, and it's very gratifying to be able to recognize this and treat it. It really does help people, and I am so happy to talk about it anytime anybody will listen. So I'm happy to be here to talk to you about it today, and hopefully be able to educate and answer questions about this condition.
Great. Thank you so much. Yeah. So I got her on here a little bit earlier and I just wanted to grill her. I have so many questions myself, even though I read about it and I look through it and I study it, and I'm still just so confused about why it's really left out. And it's not something that gets treated. It gets ignored. People don't actually know they have it. So let's start from the ground up. Let's pretend nobody has any idea what nOH is. What is it? What does it stand for? And is OH the same as nOH? Like, let's talk about that.
Right. So great questions. So OH is orthostatic hypotension. And so that's the sort of umbrella term. Orthostatic hypotension is a change in blood pressure with posture. So going from laying down to standing up. And there's a drop in the systolic blood pressure of 20 millimeters of mercury or 10 millimeters of diastolic blood pressure. So either 20 of the systolic, the upper number, or 10 of the bottom number with change in position. So that's orthostatic hypotension. And that's an umbrella term. And under that is 3 prongs. So it could be non-neurogenic issues that can be contributing to this, neurogenic orthostatic hypotension, which we're going to talk about, and iatrogenic. So the non-neurogenic issues can be due to dehydration, cardiac problems. The iatrogenic can be things like medications. So people that are taking blood pressure medications or other medications, such as some of our PD medications or antipsychotic medications or antidepressants. Sometimes those can decrease blood pressure. Neurogenic orthostatic hypotension is a drop in blood pressure upon standing or sitting up of 20 millimeters of mercury on the top number or 10 of the bottom in a person who has a neurologic condition, certain neurological conditions like Parkinson's disease, MSA, Lewy body dementia, that type of thing. So those are the definitions, and that distinguishes sort of OH from nOH. So nOH is basically the having this underlying neurological condition. And what we think, so when a person stands up, any of us stand up, there's pooling of blood to the lower extremities. And we have neurotransmitters that come out, and they help to vasoconstrict our lower extremity veins and arteries that help the blood pool upwards, and that gets blood pumping to the heart and then to our brains, and it gets all the blood flowing. Well, in people with Parkinson's, there is a deficiency of this neurochemical called norepinephrine. And so in neurogenic orthostatic hypotension, there is this deficiency in norepinephrine. So when a person stands up, they don't have that neurotransmitter or enough of it to constrict those the veins and the arteries in the lower extremity. So when they stand up, the blood pools but they can't constrict those vessels. Therefore, they can't get enough blood to the heart, and they can't get enough blood circulating to the brain, and they get the symptoms.
Okay, that was a really great description. Now I have something I want to try. Now, I haven't done this before, but I would love for people, before we like get into all of the different things that actually make up nOH. It's not just that drop, right? I mean, that is clinically the drop, but like there's a lot of things that could be happening, right? That they're experiencing and a symptom. So I would love to know first is how many, if you are somebody who you think you have nOH, just say, you know, drop it in the chat, you know, I have it or something like that. And then we're going to go through all of the different things. And then we're going to see if anything changes for those of you who think like, nope, I don't, but I'm just here to learn more about it. And then at the end of this talk, you're like, oh my gosh, I think I might have it, right? Okay. So, great. So a lot of people, yes, there will definitely be a recording. No worries. Lots of people, oh, I think I have it. I have it. I don't have it. I think I have it. I'm dizzy all day, every day. We're going to talk about that. I definitely do. Okay, cool. This is going to be great. We're going to learn something here. Great. Okay. Now, this, like I said, it seems like one of the like lesser known symptoms. It also seems, from my vantage point, that part of this is language, because we might call it nOH and somebody has no idea what nOH is, and yet they have all of the symptoms of it, but they haven't put that name to it. And so like we're kind of doing a disservice to them, us as an education company. Basically, we're trying to provide education to not kind of dig into all of the different things that it really means. And so do we, and with all that said, do we know how many people with Parkinson's experience nOH?
Yeah. So it's about 1 in 5 people with Parkinson's have it. So it's not that it's uncommon. It's pretty common in our population. And I think a lot of it is, it's just, there's a lot of non-motor symptoms that can happen to people with Parkinson's. Not that everything is going to happen to everybody, but I think part of it is, as we talked about, education and knowing that sometimes it's not just dizziness or lightheadedness. It can be other symptoms. And so that's why we're here to educate.
Yeah. All right, let's get into that. So we know that dizziness and lightheadedness is one that most people think of. They get up, and certainly if they have that 20, what is it? 20
of mercury,
millimeters or 10 millimeters, that, oh yeah, like I'm going to feel dizzy and lightheaded. But let's start there and go through the rest.
Sure. So those are the common symptoms. So lightheadedness, dizziness, near fainting or fainting. Those are the common symptoms. But there are a lot of other symptoms that can occur. And remember, always remember, this is positional. This is not happening while you're just sitting and watching television, though it can happen when you're laying down and sitting up from a laying down to a seated position. So this is positional. So some people may have weakness in their body. Some people may have leg buckling. So if you get up and you stand up, you may feel like your legs are going to give way. Other people may have cognitive changes. So this is something that the spouse or the care partner will notice. Like, my husband gets up and then all of a sudden he looks really foggy and he's not answering my questions. And that's because the blood is not circulating to his brain, and he can't possibly answer, or she cannot answer the questions because he's not all there, right? Because the blood's not circulating. Some people may have visual blurring. They can't actually see straight, again, because they're not perfusing or getting enough blood to their retinal arteries, or their arteries that go to their eyes. Some people may have what we call coat hanger syndrome. So as they stand up or even walk, they may feel pain in their trapezius or neck muscles. So that's another one. Some people may have headaches upon standing and walking. Others may feel nauseated and feel like they're going to throw up. I've heard some of the patients with nOH feel like they're going to fall into a black hole. Others can have chest pain and have a full cardiac workup, and it's not truly because of what's going on in their heart, but they're actually not perfusing their heart, so they get pain from it. And I saw this in the chat too about shortness of breath. And yes, one can have shortness of breath from this as well. So these are sort of the other sort of symptoms that can occur with the standing and the changes in the position. And usually for the criteria, it's within 3 minutes of standing. But in the literature, it can happen within 20 minutes. So it's not, that it has to be within those 3 minutes.
You mean, so somebody could be sitting down and they've been watching TV, hanging out, they stand up, and with somewhere between standing up and 20 minutes, one of these symptoms could happen.
Yeah, so a classic thing would be you're at Costco or you're at the grocery store and you're waiting in line and you've been waiting for a while, and then it starts to occur. Yes.
Okay, so that has to be even more confusing.
It is, it can be, definitely.
Yeah. Okay, that's super interesting. Somebody says, would nOH cause a blackout?
Yes, absolutely. It can cause a blackout. So if
Okay.
you're blacking out for no, quote, no apparent reason, that's all the more reason to talk to your physician about, could this potentially be from nOH? And then you should be worked up for that.
Okay. And somebody, well, they're asking, how does it get diagnosed? And like we said, it's a blood pressure thing. So if you're in the doctor's office, you are going to check their blood pressure, and you're going to do probably a couple of different rounds, right? Where they're sitting, they're lying down, they're sitting, they're standing, right?
Yeah. So what I'm going to do is I'm going to do a detailed history. Of course, I'm going to go through their medications and make sure that I don't have any offending agents, right? So, in terms of the Parkinson's world, shorter acting medications, dopamine agonists are culprits. If a person is taking dopamine agonists several times per day, maybe using an extended release one would be a better choice. Anything extended release is better than the pulsatile ones. What's that?
For this,
yes, to reduce the symptomatology. Also, people also will have more symptoms in the morning. So that's traditionally what happens with people with nOH. So their symptoms are going to be much worse in the morning and typically get much better as the day progresses. And you may have symptoms after eating. And that's because the arteries and veins in the stomach, they pull the vasculature, the blood to there. So I will ask them these kinds of things. And also, do your symptoms get better once you sit down? So that's another pearl. Does the symptoms get better? So then, yes, of course, I'm going to do my orthostatic blood pressures. I'm going to take the blood pressures. I'm going to have the person lay down in my office for 5 minutes. And then I'm going to have them stand up. I'm going to take a blood pressure and a heart rate after 1 minute, and then take it again after 3 minutes. And then I'm going to see, is there a drop on either the systolic or the diastolic of either 20 millimeters of mercury or 10. And then another thing that is important to recognize in nOH is that the heart rate does not increase. So if it's just regular OH for one of those other reasons, the heart rate is going to increase. And in nOH, it does not. So it will be blunted. And so that's another diagnostic pearl for us to look at.
Great. So you're looking at heart rate on all of those tests, and basically in an nOH situation, the heart rate stays the same throughout the whole thing.
That is correct. It may go up about 5 or so, but it doesn't go up a lot like it would if you were dehydrated or if you were bleeding, God forbid, or something like that.
Right. Okay. There are so many, I don't want to get ahead of myself. So there's tons of questions that are just like clarifying. And I think it would be good to go through some of these. So, Somebody says something about a couple of people have said when they're walking up a hill, going upstairs. Is this equivalent to sitting down to standing up? Is just you're standing, but now you're going up?
Very much so. So that's very typical. And that can be one of the first symptoms that people have. Going up a hill or going upstairs is very, very common. So you have to be careful. And yes, that can be an indicator. Absolutely.
Okay, excellent. Is nOH related to lower extremity edema?
No, it is not.
I'm dizzy all the time, but when I stand up, my blood pressure does not go down.
So the dizziness is likely from something else.
Great. Okay. Can it lead to AFib?
No, it's a different pathophysiology. Now, it doesn't mean that one can't have nOH and atrial fibrillation, but the pathophysiology is different.
Somebody says, how do you know? Because you did mention it earlier that it could be something else. And I wonder, I do think some people will get a different diagnosis. Maybe they're originally diagnosed with Parkinson's and then they find out it's actually PSP or MSA or something else.
Yeah.
So how do you know that it's not, let's say you're early in your diagnosis and you said MSA, how do you know it's not MSA?
Well, that's a great question. So MSA, and you don't know right off the bat, right? So typically people with MSA have profound drops in blood pressure, and it happens earlier on in the disease. Not to say that nOH can't happen early in a person with Parkinson's, but they also have a lot of very significant other autonomic issues, urinary problems, inability to hold their bladders, bowel incontinence, those types of things that happen in MSA that one wouldn't see as much early on in people with Parkinson's, particularly the urinary issues.
Okay.
Incontinence that early on.
Let's see.
And in MSA, the blood pressure is so debilitating that they are often wheelchair bound because it's so profound.
Can't function, right? Do the reasons for OH and nOH overlap?
So nOH is a type of OH, but with a neurological condition associated with it.
This is a question. Is this something for people with Parkinson's that typically gets worse over time? Certainly if not treated, but is it like a progressive symptom, like maybe their motor symptoms get worse? Is this nOH get worse over time?
Well, it needs to be treated. If it's not treated, certainly it will. But if you treat it, it pretty much stays stable, but it needs to be treated, and sometimes very aggressively.
Okay. Well, we'll definitely get to that. Somebody said something about, a couple of people said freezing hands and feet. Like, is this a thing? Or maybe a circulation or just
yeah, and that's very much a Parkinson's thing. People, just in general with idiopathic Parkinson's, the thermostat is off. So people sweat, people have really cold hands and cold feet, but not related to nOH.
Okay. Sorry, MSA, multiple system atrophy. I'm sorry about that. Written that down. And we will also be sharing links to anything that we talk about here. So we'll be able to talk a little bit more about that. Okay. All right. Let's see here. So you talked about treatment, absolutely has to be treated. Is there any way that people can treat it non-pharmacologically?
Absolutely.
And what are those? And then what are the pharmacological treatments?
Sure. And we always start with non-pharmacological treatments. And if and when those non-pharmacological treatments don't work, they stay the course of your life. So nOH is it takes a lot of education. It's a lifestyle change. It really is. So first and foremost, people that have nOH, 70% of them have supine hypertension. So in other words, when they're laying down, their blood pressure is high. So they have to sleep with the head of the bed at 30 degrees because they are at risk of having a problem at night with their blood pressure being way too high. They also tend to urinate a lot overnight because of this. So it's really important that they sleep with a wedge pillow or whatever they can utilize and get, be comfortable with for that reason. And then another thing that's really important is people get caught up in blood pressures, and that's not the goal. The goal is not to get the person to be 120/80 every day, all day, because that's not going to happen. The blood pressure is going to bounce up and down throughout the day. The goal is to get your symptoms better, whatever those symptoms are. And now, some people know that when they go below 90 systolic, they're going to pass out. But there are other people who walk into my office and their blood pressure is 70 systolic, and they're having a full-on conversation with me with no symptoms. So people auto-regulate. And so I urge you not to get too caught up on the numbers, but more the symptoms. And that's
the like differentiation, the relative difference of all the numbers.
Right. Exactly.
So when you said the supine hypertension, is there any relation that says like, oh, if you have this, you're more likely to have nOH, or is that not related at all?
Well, I think the thing is if we start to see it, we start to look for it once we notice that the person has nOH. So we're not really looking at supine hypertension until we find that the person has nOH, and then we're really all over it because we don't want people sleeping flat.
Right. Okay. Okay, great. All right. So
that's one thing. The other thing is hydration. I mean, there's not enough to be said about hydrating with water. And again, remember, your symptoms are going to be more in the morning. So we really push the fluids in the first half of the day. Tanking up, it's super important with water, with electrolytes, G2, anything that, and then salty snacks, soups that have sodium, things like that are going to increase the volume are really important. V8 juice, those types of things, as long as it's okay for you to increase your salt, as long as it's okay with your doctor to have higher salt. And then removing any aggravating, causes like hot weather, hot saunas. You don't want to go into a sauna because that'll drop your blood pressure. Really hot, steamy showers, that'll drop the blood pressure too. So maybe if you like taking hot showers, do it later in the evening, and don't make it so steamy. Other things,
can you, so on that heat piece though, so is this also then true for, people who exercise very intensely and they sweat a lot and they get really hot? Is this going to trigger anything nOH?
No, because it's the external heat, not what they're producing. But if you go and you exercise and then you go into the steam room, you may pass out. Yeah. Especially if it's in the morning. The other thing is carbohydrates, large carbohydrate meals. That can precipitate drops in your blood pressure. So you want to start eating smaller, less high carbohydrate meals, and so avoiding that. And then some people utilize compression stockings, but what's really effective are abdominal binders, things that will squeeze into the abdomen and these bigger vessels, and that will increase the blood to the brain, and that helps a lot more than the compression stockings too. Okay. And sometimes
someone said they wear Spanx.
There you go. Yeah.
So if somebody has it and they're thinking about using a compression sock or an abdominal band, is there anything that you would say like, hey, I limit it to a certain amount of hours, or hey, you could wear that all the time, or what?
Do not wear it when you're laying down. So again, you don't want anything compressing while you're laying down because you may have supine hypertension. So that would be what you would not want to do. Yeah. Great. And then switching over to what can we do and and then the other thing is getting up slowly. And this is really hard, because people just think, okay, well, I'm just going to get right up out of my chair and move on a lot. it's really an education piece, right? So you really have to think about not darting out of your chair, got to get up slow. And then if you do exercises like leg lifts or leg crossing to exercise those big muscles of your lower extremities, that too can help get those get that blood flowing and minimize the drop in the blood pressure when you stand up. So that's another sort of pearl to utilize before standing. And in terms of medications, so there is one FDA approved medication for this condition, and that's droxidopa or Northera, and that is a precursor for norepinephrine. And so that is that's available, and it's been available since 2014, and it acts peripherally and centrally, sort of to replete the norepinephrine. And then there are 3 other ones that are used and have been used sort of off-label. One is midodrine, and that is, it acts peripherally on the arterial and venous system. And then there's another one called Florinef, and that is a vaso, I'm sorry, it's a corticoid. So it's a volume expander. It increases the volume and then therefore increases the blood pressure. And then the third is Mestinon. Mestinon is a medication that is used for myasthenia gravis, but it does have some properties to increase blood pressure a little bit. And that does not tend to have the supine hypertension that the others may produce. So those are the 4 that we utilize. And oftentimes we have to use them in combination to get adequate efficacy.
Okay, yeah, I was gonna say, like, on because there is that one Northera is labeled for this specifically, in what instances, what are some of the things that people might experience while they take it that actually doesn't work for them, or they do need multiple different ones to treat it?
Right. And so every practitioner is different, but, again, the goal is for the symptoms to be better. So, your practitioner may start with whatever, and then if your symptoms are not better, they may add on another one. The goal is to get your symptoms better, but not to get too much supine hypertension or have supine hypertension. So it starts to become a slippery slope. Particularly if you're having supine hypertension. Again, very important that you sleep with that head of the bed at 30 degrees to avoid that.
Okay. Great. So a couple of other questions. Let's, somebody said something about, clarify, is this diagnosed by a general practitioner, a neurologist, or a cardiac doctor? Other people said my movement disorder specialist diagnosed me. But interesting, again, like what is the general practitioner, what is their experience with nOH? And is this something that yes, they can easily diagnose it? Would they even know to look to diagnose it?
Honestly, I don't know the answer to that. And I think it really depends on them and on where a person lives. So, there's a lot of really astute general practitioners that know to look for this. But it really just depends, to be honest. And, a lot of healthcare providers don't have a lot of time. Doesn't matter if it's a neurologist, a movement disorder neurologist, a cardiac doctor. I worked with hand in hand with a lot of cardiologists, and this sort of awareness about it, because they were seeing a lot of people for fainting and syncope, or and they would see them from the ER and they would diagnose them. So really, it just depends on where they're coming from. But it's the important thing is that practitioners have it at top of mind, that this could be a part of Parkinson's. And if they don't, then I urge you all, if you have any symptoms of this, to bring it to the attention of your practitioner, whether that is a general practitioner, a neurologist, a movement disorder neurologist, or a cardiologist, that you can bring this to the attention of them and say, hey, you know what, I saw this webinar, I am having these symptoms with standing, I've checked my blood pressure sitting and standing, it is dropping, I think I may have this condition, can you please help me? Because a lot in today's medicine is us being our own advocates and taking the reins, and that's okay. I mean, we're just here to help ourselves too, and to be the best us we can be. So
right. And I think that is, interesting for people, that if it's hard to get to a doctor or you can't get in, and now you're really curious, there are at-home blood pressure cuffs that you can get. And, somebody will say, well, it's not a very good cuff. Well, all you're really trying to do is look at the differential, right?
Definitely.
So it's going to be wrong. It might be wrong both ways, but it's going to show a change. So that's a super important thing. And something that you can do on your own. And curious, I'm going to go back to these questions, but I would love a lot of good questions. I would love to know, has anybody, based on all of the symptoms and all of the different experiences that Dr. Brillman just talked about, is anybody on the, I don't have it, I'm not sure if I have it, now thinking, oh gosh, I think I might have it. If that's the case, throw it in there. Okay. And then somebody said, I have obstructive sleep apnea. Is there any bearing on treatment for somebody who has this as well?
No.
Okay. Great. Somebody said taking salt tablets. You could do that instead of a chip. I like that better than taking chips. Let's see. Can altitude affect nOH?
No.
Somebody says, I'm not able to exercise strenuously because I become overheated, dizzy, and short of breath. My guess is that would be something unrelated, but
I believe so, yes.
Okay. If you are having an episode, should you skip your blood pressure meds for that day?
An episode of nOH? Well, I would talk to your doctor about that. I think that's the best bet. And you also want to make sure that it's actually your blood pressure is dropping. So not take it upon yourself to, and also, why are you on the blood pressure? Is it for, perfusion? There's lots of reasons why people are on blood pressure, not just to decrease their blood pressure. So, but that said, a lot of people with Parkinson's have a history of high blood pressure, and then over time, they don't need their antihypertensives, but they're just kept on. And so having someone look at your blood pressure or look at all of your medications and taking a fresh look at it is a really important thing, whether it's your blood pressure medicines, whether it's your Parkinson's medicines, whether it's your urinary medicines, whatever the case may be, not just saying, okay, you're fine, you've been on this a long time, let's just keep it going. Because, as we grow older, our kidneys grow older, our livers grow older, and maybe you don't need quite the same dose. So it's important to have things looked at.
Great. Does anything that we like, coffee, alcohol, anything that people drink, have any bearing on it? Caffeine, anything like that?
Yeah, so thank you for bringing that up. So caffeine is a diuretic, so it's not going to help your blood pressure, but alcohol will drop your blood pressure. So in people that have nOH, we really, recommend decreasing the alcohol. I have patients who like to have a cocktail in the evening. And I always recommend, if you're going to have a cocktail, make sure you have a lot of salty snacks and drink a lot of water with it. So that your blood pressure is not going to drop too much and you have something to compensate for it. You don't want to go having, a mimosa in the morning, which brings me to another point. So sugary things, we talked about carbohydrates, but juices will drop your blood sugar. So if you are one to have, juices in the morning and you feel lightheaded in the morning after breakfast, cut out that sugar of the juice, because that could be something. Remember, carbohydrates are culprits here in dropping blood pressure. Great.
Somebody says, does everyone need to use a wedge? And no, that was just, you were just talking about people who have supine hypertension.
In my practice, anybody who has nOH has bought themselves a wedge or.
Okay, great question then.
Yes, it is. Because the likelihood is they have it or will have it, even though in the literature, it's about 70%, but I don't want to take any chances with my patients.
Great. Let's see. Yes, hoping we can spread awareness. Agreed. To hospitals, even the rehab floor, who just don't recognize or understand the importance of it. For sure. Are there other conditions that mimic nOH? I think, we talked a little bit about that, is things like dehydration and a cardiac issue, something unrelated that can,
Congestive heart failure medications, like I said, the high blood pressure medications, those kinds of things.
Okay. If you have nOH, should you also try to have autonomic testing?
Okay, that's a great question. So if you have a diagnosis of nOH and Parkinson's, you don't need to have further autonomic testing. However, for people that have trouble getting a diagnosis of nOH, one can get autonomic testing. So there are dysautonomia centers or autonomic centers around the country that do tilt table tests and different autonomic testing that can clinch the diagnosis. If you're one of those people that are really hard to get a diagnosis, that it's not just so easy with sitting and standing after 10 or 3 minutes or 20 minutes. So
Okay.
that can clinch the diagnosis.
Can you tell people a little bit more about what autonomic testing might look like? I'm guessing.
Yeah, so they do for nOH, they'll do a tilt table test. So they'll put the person on a table that tilts. They'll tilt them back for a few minutes, and then they'll raise them up, and you're connected to a blood pressure cuff, and then we'll see if there is a drop in blood pressure, and then also look at the heart rate. And some people will not only have the drop, but some people actually faint on it. But they're laying on something and they're strapped in, so they're safe. But that's pretty much what a tilt table test is.
Okay. Someone said, I struggled with this for at least 5 years prior to my PD diagnosis. So like a big prodromal symptom?
Yeah, it can be. Wow, that's really hard because, that's the thing that is really sad, because I think people, the quality of life in a person with nOH is dramatically affected, and people are afraid to go out. They're afraid to be away from their home because they're afraid that they are going to have these symptoms and not be able to control their surroundings. And so I think it's really important that, well, of course, awareness is raised, but if you have these symptoms, to bring it to the attention of your healthcare provider and then use the non-pharmacologic treatments. But if you do need treatment, to get that.
Yeah, absolutely. Actually, we talked about this a little bit before, and somebody says, can nOH lead to convulsions, a seizure, anything like that?
No, people can have convulsive syncope. So when a person
Well, they did
faints,
say that too. Yes.
yeah, they can have a convulsion, but it's not a true seizure. It's a convulsive syncope.
Okay. There's a lot of people asking questions about the wedge. Can you use, I'm just going to show you 3 out there. Can you use a wedge if you sleep on your side? My doctor thinks a wedge might not be good because it bends the middle section of the body. Does the wedge have to be a full body, or is it a bend at the waist wedge okay?
So the whole point is to get from the middle of your back up, so that right around your heart upward. And that's the whole point of it. So it's not a full body one, it's just from the middle up. It is exceedingly difficult to sleep on your side, from what I understand from my patients. The other thing, and this is not for everyone, but there are these beds that one can get that lift one part of the bed up, or a hospital bed too, if the wedge is very uncomfortable. But I know it's really hard. I know it takes getting used to. I've, for 7 or plus years now, been talking to my patients about this, but they do get used to it. And it really is worth, because you don't want, God forbid, to have really high blood pressure while you're sleeping and lead into those kinds of problems that can occur.
Great. Yeah. Somebody asked about, all this talk about standing, but what about lying down? Doesn't that bring effects? And again, like the whole thing is that could be, it's unrelated. It's something else going on that it could be. I'm sorry.
The effects of what? Like,
well, just lying down. Can you have these effects while lying down, these symptoms?
No, that would not be nOH related.
That would be something else.
Yeah.
Okay. Yeah, well, this is good. Great. And glad you brought it up. Can you drive safely with nOH?
So, if you don't have symptoms while you're seated, you can, because this is something positional, right? So these symptoms occur when a person goes from a lying to a sitting or standing position. Now, if you're the type of person that is having symptoms after a long time of being seated, then I would say no, it's not safe. But if you don't have any symptoms when seated, or your symptoms go away, then you would.
Great. So the other thing I wanted to talk about is sort of consistency of symptoms. So is this, if somebody truly has nOH, is this something that every time they do it, they experience the symptom? Or is this something that could be like, oh, every 5 times I experience it? Or is it really predictable?
That's a really good question. So it really does, they're going to get the symptom when they fall below the level of their auto regulation. So for instance, the gentleman or the person I was talking to you about who walks in and he's at 70, right? Systolic. When he falls below a certain say 65, that's when he gets symptomatic. So, but not every time is he below 65, right? So it really just depends on when and how far they go. I have patients, like I said, they know when they're below 90, they're out.
Right.
So it just really depends.
And so if somebody is experiencing it, though, it's just, it's happening every so often. I mean, they're obviously, they need to do the lifestyle changes, right? They need to hydrate, they need to do all of the things, sleep on the wedge, try and all of those things that we talked about. But at what point does medication become the thing if it's not something that happens every time?
If things are not improving with those lifestyle changes and they are still having the symptoms, then
At all.
Right. One should consider adding a medication.
I found that a strong Starbucks coffee and a sweet pastry in the morning exacerbates my nOH.
It's the sweet.
It's going to exacerbate a lot of other things too.
And the carbohydrate load is dropping your blood pressure.
Right. Doing back bend when standing helps me get rid of the dizziness right away. Is this okay?
I suppose you're getting the blood circulating back into your head. So
right. Yeah. I mean, I would say you must be very adept at doing back bends, and this is part of your natural practice. But I would say that's kind of risky, only because if it doesn't come back, you're going to land on your head. Maybe. So, yeah. Maybe going forward is better if you're gonna. Well, here's sit down.
That's exactly right. So here are some tips if you are acutely dizzy. Definitely sit down, or find a place to sit immediately. If you're acutely having any of these symptoms of nOH, you want to sit down. If you are about to pass out or you're really, really symptomatic, the fastest way to turn that around is by drinking a big glass of cold water. That will get your blood pressure up the fastest way. Alternatively, if you have nOH and your blood pressure is high, let's say you're taking it for whatever reason, and you're high and you're nervous because it's high, or your spouse is nervous, stand up and walk and it will get lower, or eat something, with a large carbohydrate load, and then it will drop. So those are the things to do to mitigate those possibilities of either very high or very low blood pressure. It's better than taking a chance of bending and things like that, because like you said, Mel, it can, it's risky and you could fall and hurt yourself. And again, falling, and that's the thing, if you fall, it leads to fractures, it leads to mortality in Parkinson's, and we do not want that. That's why, it may seem like, oh, I have a little bit of this, or I'm, a little bit of lightheadedness, but it takes one time to have a fall to lead to a fractured hip, to lead to this, that, and the other. And we don't want that. We don't want any of you in the hospital with Parkinson's.
Yeah. Great. This is interesting. Somebody says, if I get breathless and lightheaded walking, I clench my butt muscles and it helps.
That's exactly right.
You're bringing the blood, right?
That's exactly right. From the bottom up. And if you clench your butt muscles, your lower extremities, before you stand up too, and that's exactly right. That it will help. Absolutely. Thank you for that.
Yeah. Somebody says, I've had low blood pressure my whole life. Do I really need to I can't speak today, measure my blood pressure while supine, or is it safe to assume that I'm not a candidate? I would say if you have Parkinson's, doing this is critical. You should.
Yeah, I would
take it. Yeah. Okay, I teach pedaling for Parkinson's at the Hi, Tom. RPM between 50 and 90, depending on the number and their own situation. Could nOH occur from seated bike position to the standing position? Yes. Right. So seated and then standing up to maybe do a hill and go faster. Yeah. Right.
Yes, sure can.
Yeah. So that's a really good thing.
Laying to seated, or laying to standing, or seated to standing. Yes.
So, in that case, it would probably be worth it to talk to the group, to talk to people that come to your class, especially coming for the first time, and saying, hey, everybody here has Parkinson's. One of the symptoms that we have here is nOH, and this is what happens. And maybe if they're unsure, have them do the test, right? Like at home, and see if is that something that happens to them all the time. And if it is, be like, hey, just stay seated. Right? Just stay seated on the bike. You don't have to get up and climb or go fast while you're getting up. Just stay seated.
Or drink a lot of either like G2 or a lot of water before the class to tank you up prior to. And that'll help.
Keep your water bottle with ice in it in the bike.
Absolutely.
Would be nice. I can't remember. Okay. So somebody says, I experienced the drop in blood pressure, but it doesn't clear up and I'm unable to function. I can't move around. It intensifies if I move around. So that if it never goes away, sounds like there's something else going on. So yeah,
if it doesn't improve upon sitting, then it's likely something else.
Great. Okay. I think we've covered almost every question that I have. Is miles per hour like POTS, POTS? I'm not sure. Maybe Tom, maybe I'm guessing Tom could answer that question. Where to go if it's something else? I mean, well, you're still going to go to your primary care doctor, or if your movement disorder specialist or neurologist says, we've done the test, it's not nOH, it could be X, Y, or Z. They may refer you back to your PCP, maybe your primary care physician, or they may refer you to a cardiac specialist. There's a whole different set of things that they could do. They're going to be the best people to know what your next step is.
Yeah, definitely. Cardiac workup is important to look at the structure and the electrophysiology of your heart too.
Right. Once I've experienced it, I can feel ill for most of the day. Is this typical? I mean, you did say some people can anywhere from standing up to 20 minutes might feel it. They might feel nauseous.
Yes.
Is it normal for people to also like sort of have that feeling throughout the day if it happens once?
From my understanding, yeah, from the nausea, for those people that get nauseated, and that is not, and fatigue is another one too. So, so nausea, fatigue, headache, and yeah, could it take a while to dissipate over time? Yes, it could. So, so if that's happening, it's worth trying to see, do I have this? And should I get treated for it so that I don't precipitate it and maybe try to avoid it even.
Right. And yes, if you have Parkinson's now and you do not have nOH, yes, you could develop it later. You
Yes.
might not
It
come
can,
for a while.
correct. It can happen at any point in a person's life. Yeah.
Great. Is there any question that you get or questions that you get from your patients that I haven't asked that you think we should ask so that everybody really has everything they need to get prepared for their next doctor's appointment?
Write down your symptoms as they're happening, and don't be afraid. Like, just remember that not everything, even though it's blood pressure and you think about dizziness and lightheadedness, it's not always like that. It brings me to one patient who had nOH, and I'm a movement disorder specialist. Like, I should have caught this, right? So he kept telling me I can't finish my 1 mile walk. And I thought he was wearing off. I thought his meds were wearing off. And so I tinkered around and, changed his meds, this, that, and the other. And then he was never dizzy, never lightheaded, ever, 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 ever. And it turned out it was his blood pressure. And so by the time he was done with that, like on the way done with his 1 mile, his legs were giving way, and it was because of his blood pressure. And so even though it may not seem like it's the norm or it fits into something, just write it down. And if you think that that might be the situation, then bring it up to your physician. It was one of the most gratifying things, because when I did treat him, he was like, you gave me my life back. Now I can cook, I can take my mile walk, I can do things again that I wasn't able to do because my legs were giving way. So it's really, really important. Just whatever your symptoms are, write it down, bring it to the attention of your healthcare provider, and be your own advocate.
Yeah, well, I think that's great. Somebody asked, are there long-term effects to not treating the nOH? And I think quality of life is one of the biggest ones. You also talked about falling. There are a lot of downstream impacts of having nOH untreated. And, we were talking before this started that a lot of you may have 15 minutes with your doctor. If you're lucky, you have more, but many people don't.
Right.
And you might walk in presenting with something obvious, or you went in because you had something that was on your mind. And before you know it, the time is up and you didn't have the chance to say, oh, by the way, I was noticing I get up and I'm a little dizzy, or I'm noticing that my legs are buckling. And so I think this idea to just really make sure that you sit down and write them down. And if you have a care partner that notices things, write all of these down. One way to do this is to send it ahead of time to your doctor. If they have a patient portal, put it in there. A, it's a great record for them to have. And then B, it sets it up for the appointment. They're more likely to bring it up. You're less likely to forget because it's going to be prompted. And it's a good thing to just kind of keep having in your record all the time that it's happening, right? So you can progress, see if it's getting worse, see if it's getting better, especially if you start to treat it again. You're going to say, oh, this medication is working, it's not working. And so I think that I've gotten in the habit of telling people to use the patient portal a lot more now, because it's a great record and it allows you to kind of get more in than you might have in those 15 minutes.
And that's so true. And I think also, especially with something like nOH, you should not have to wait until your next appointment. So if you're symptomatic, you need to call your doctor and make an appointment, or tell them via the portal, whatever the case may be, but you don't want to have to wait 3 months or 2 months or however many months. As I always say, people with PD are so stoic and they'll take anything that's coming to them, but this can be a safety issue. So don't do that. Like, if it's happening, let them know now. If it's mild and, it's very infrequent, fine, write it down. But if it's happening with frequency, don't wait the time, because you don't want, God forbid, something to happen and you faint, and they should know. I know I would want to know. I would not want to know at the 3-month mark. That's for sure.
Right. That actually reminded me, one last question before we end. With something like Northera and maybe some of the other ones that you talked about, and please know that we will send all of the information and all of the medications that we talked about today in the show notes. But with something like Northera, is that the kind of medicine that actually starts working right away, or does it have to be in their system for quite a while for them to notice that it's working?
So, so Northera needs to be titrated. So the maximum daily dose is 600 3 times a day. And we start at a low dose and increase every 24 to 48 hours. And we titrate it up to when a person's symptoms are improved. Usually takes with about a week to 2 weeks to get to that point. And the person will know within about a week or so whether they're feeling better. Midodrine is faster acting. But it spikes up, and but you can feel it working a lot faster. Spikes up, spikes down, spikes up, spikes down, and more supine hypertension. Flornef is it works within a couple of days. So there's that, and then Mestinon. That's usually the last add-on that a person will use. We generally don't use that as a first go-to.
Okay. Great. Well, thank you so much. This is so incredibly helpful, and I know that our community loves it. I learned so much today, and I'm really, really grateful for you to be here today.
Thank you so much. Thank you for asking me to be here. I really appreciate it. And I appreciate it so much. Thanks, everyone.